and welcome to this episode of Conversations in Health and Care Improvement. I'm Amar, National Clinical Director for Improvement in England and the Chief Quality Officer at East London Foundation Trust, and it's my real pleasure to co-host this series with Pedro Delgado, the Vice President at the Institute for Healthcare Improvement. Today, we're super excited to focus the conversation on the topic of people and how to activate people's agency to make change happen, really learning from other approaches to change that might be able to help us in the work we're doing in improvement. And delighted to have two fantastic guests who can help us explore that topic. Kate and Mike, let me introduce you both briefly and ask you to say a little bit about yourselves. So let's start with Kate. Kate, you're the co-founder and principal of Innovation Capital, and many people around the world will know you as being an expert in the field of the psychology of change. So it's an absolute delight to have you with us today. Kate, hi.
Thanks, Amar. Yeah. At the outset, I think it's important just to acknowledge the approach I take to change, which is to answer two key questions at the outset of any type of improvement or innovation work. And the first question is, who are our people? And the second question is, what matters to us? So this approach involves centering on the people that are experiencing a problem and activating them to be the authors of the solutions, equipping them to use adaptive leadership methods to achieve results. And so over 15 years, my work has been to equip leaders at all levels around the world to build individual and organizational capacity to address the adaptive human side of change in improvement work, in patient safety, in health equity, and in workforce well-being. And my educational background is in law and theological studies, but my practical background is as a community organizer working in social movements, in leadership development and change management. And for years before committing to organizing in the field of health and healthcare, I worked with storied community organizer Marshall Gans, which was an incredible education.
Fabulous. What a rich history and also a diverse set of experiences, Kate, you bring. I know we're going to dive into some of those areas and learn from your experience in the course of this conversation. And also a real privilege to have Dr. Michael Rose with us. So, Michael, you're a physician by background and Senior Vice President and Chief Innovation Officer at McLeod Health. Welcome. Mike, tell us a little bit about yourself and the work you've been doing and what brought you to sort of really deepening your understanding into this aspect of change.
Yeah, a practicing physician and have had a variety of roles here at McLeod Health over the years, starting in the medical staff organization and then as an operational leader within surgery, which is where we came across one of the most complicated but pivotal change management opportunities that I've had in my career, and then was lucky to work with this team on solving for that. And since I've been taking those lessons learned into my role as an innovation and transformation officer for the organization. And we all know that the ideas, the innovations to become reality have to be executed. And that execution is a people process, and nothing in healthcare can be done with a person, requires a lot of people. It's applying that learning that as good as an idea is, it can't reach people in a meaningful way unless it is organized among people to achieve it.
That's so true, Michael. Pedro, we've got two great guests with us today, and the topic is about people and what we can learn from community organizing, from social movements, from our understanding of what drives people's behavior to help us in the work of improvement. What are your thoughts about the topic and what we should be trying to explore together today?
Well, first of all, Michael and Kate, thank you for being with us. I still remember a couple of days we spent together when I met both of you at the Charles Hotel little conference room in Boston, with a number of people from healthcare who were just so hungry to hear from the group that came to facilitate and to teach us about community organizing. And on that day, Amar, just to go back to your question, I was really struck by the underappreciation of the human domain of how we work as people and as teams. We get very transactional and technical, and we were grounded in many things, including some human behavior. But this just took it to a very different level, and I'm really curious if you don't mind me kind of asking a question. There's a lovely definition of leadership that has stayed with me for a long time since I heard it then, and I don't think it has changed radically now. But maybe Kate, can you remind us what that is and what it means?
Absolutely. Thanks, Pedro. In the realm of community organizing, we view leadership as accepting responsibility for oneself to enable others to achieve a shared purpose in the face of uncertainty. And as such, it's a lot less about knowing than it is about learning. It's a lot less about asserting control over uncertainty than developing a capacity to respond to uncertainty with purpose. And it's also much less about a position than it is about a practice or a way of doing things.
And that is so powerful for the current times. Accepting responsibility. So there's sections to that definition. That means that I don't necessarily work on blaming others, but I accept it and I do what I can. In the face of uncertainty, I mean, the only certainty that we all have is uncertainty. Enabling others, meaning less self-centeredness and more on service. Where you've seen exceptional leadership, what has it looked like? And when you've seen challenging leadership, what has it looked like? Give us a contrast in the context of the psychology of change and community organizing, when you're trying to build movements, bring people along and so on. When it works really well, what does that look and feel like? And when it doesn't work very well, what does it look and feel like? And what are some of the things that you've learned along the way?
Yeah, I'd say as an exceptional leader is a colleague who was instrumental in our quality improvement work, and is now our chief executive officer, and taking on that role after her first 20 years here as the quality leader, now CEO, Donna Isgett. And one of the things that she used as an aligning principle across the diversity of the organization was that quality is our objective. That's the shared purpose for which we all can contribute. And that when we can establish that, then the roles and the contributions can fall into place on how they contribute. And within healthcare, and of course managing one of the most complicated hierarchies is the one that involves physicians. And so what I thought was particularly powerful was aligning the physicians around that quality mission, and stipulating that in our organization we were going to be physician-led, evidence-based, data-driven. And so the terms of the conversation were shifted from being about who and what was their position and what was their role to physician-led, evidence-based. Let's not talk about the who as much as the what and how, and to the extent possible is use the science of learning and improvement and evidence to guide what we choose to work on, and then follow on from there into is it working or not, and to repeat that mode over and over and over. And so here's the problem to solve. Here's a group of physicians and others we're assembling to solve it. What's the evidence? What could be a plan that people could contribute to? And then how's it working so that we can agilely adjust as needed on what might have been the best laid plan to is it getting a result? And I think that framing principle has stuck with us and can be applied as we get to bigger and bigger and bigger problems and problems to solve. And what I would say as less effective leadership was, and I've been here long enough that I was part of the before of when we didn't organize and align around that approach, and where lots of things got done and we were really busy, but the big system measures weren't changing. And it's possible to be incredibly busy side by side, getting a lot of things done, but not getting a lot of things done that were moving the whole system's capability over time. And so I contrast those two experiences, and one of the best demonstrations of that, I think, was in the Safe Surgery project that we did here as probably one of the first enterprise-wide bodies of work of that type that we've now tried to emulate and repeat on more and more difficult problems that the organization confronts over time, especially as we've grown very substantially over the last 10 years in particular.
I'd just like to pipe in on this one. Mike is being extraordinarily modest because the first person that came to mind when you asked him that question, Pedro, was Mike. What you asked about, what are movements that demonstrate a certain type of leadership, and I would contrast, especially in healthcare, two different types. So one is a leader-led movement, where we're really familiar with that in a hierarchy setting of having a charismatic leader at the top, where there's centralized decision making that flows down, and it's a command and control approach. Leader-led versus leader-full. So a leader-full movement would be something where you're seeing empowerment of many at the core of the work around a shared mission, collaboration over command, and shared leadership, which is what Mike embodies. And the types of qualities that Mike demonstrates in his work is listening so deeply that it changes not just Mike, but changes the direction of the work in order to be responsive to the people who are involved in it. It subsumes, your own ego to the greater cause or the greater mission, which you can hear him, describing, and that there's a relentless focus on impact, that you see the bigger picture, you know what you're trying to achieve. You're using improvement tools to do that. And you're trying to catalyze collective leadership. You're actually paying attention to building other people's capability to lead and do the work, to distribute that leadership across many. And Mike is a wonderful example of that type of leadership.
Fabulous. It makes me think a little bit about, the system of profound knowledge that Deming described. A lot of what you're saying epitomizes that sort of way of thinking about the system, really building a theory and enabling everybody to contribute to the theory about how to make things better, using data and understanding variation. And the fourth part is around people and psychology of people. And Kate, I wonder whether you might help our listeners understand a little bit about the fields of social movements and community organizing, because they're not commonplace in the way that we think about or talk about or teach quality improvement. And I just wondered whether you might help people understand, what are they? Are they sciences? Are they methods? And what similarities or differences do they hold to the way that you see people going about quality improvement work at the moment in healthcare?
Yeah, thank you. Well, organizing itself is a set of practices. And if we kind of look back historically, this has been going on in the world for many, many years, from the days of the Exodus and the Greeks. In fact, in the Irish revolt against British landlords and the famous Captain Boycott, where we first coined the term boycott. And so, they've been around a very long time, and they are used for the politics of change. So if we're interested in improvement, all improvement is change. And so there's a very strong Venn diagram over thinking about what can we learn from historical movements, moral reforms, often, things like agrarian reform, labor reform, civil rights, environmentalism, gender equity, and what they really work to do is expand equality of voice. When they do, they can strengthen democracies, When they narrow equality of voice, the thrust of, for example, populist authoritarian movements, they weaken democracy. So there are many types of movements. You can learn a lot from all kinds. And then there are movements that are very specific to healthcare. I would, before going into the types of movements within healthcare, I want to talk a little bit about organizing. We talked about leadership at the outset. Organizing can be understood as a form of leadership. And as Marshall Gans often quotes, first century Jerusalem scholar Rabbi Hillel asked three key questions. The first question is, if I am not for myself, who will be for me? And this is the idea that it's not selfish, but instead self-regarding. So if we as improvers presume to lead with integrity around the changes we seek, we need to bring a clear understanding of our own values. That's a question of, what matters to me, right? And then the second question that Hillel asked is, if I'm for myself alone, what am I? And here, it's very interesting. Hillel uses the word, what am I? So to be a who, a person, and not a what, is to recognize that we're deeply interconnected. We live in a world of relationship with one another. And in our systems, our capacity to realize our objectives is inextricably wrapped up with the capacity of others to realize theirs. And the third question that Hillel asks is, if not now, when? And this is not advice to jump off a bridge. But it is something improvers love, which is what can we accomplish by Tuesday, right? It's a recognition of the fact that we can rarely know what it is we need to know without getting into action. So understanding about what we do flows from action, the classic plan, do, study, act cycle. And the fact that these are framed as questions is because leadership, as we talked about, doesn't have all the answers. It doesn't have all the answers. It's about learning to ask the right questions. So from there, organizing is a particular form of leadership, and it asks three questions. Who are my people? Not what is my issue, but who are my people? What change do they need, rooted in their lived experiences? And how can they turn their resources into the power that they need to achieve their goals? So it's not about providing services, and this is where it gets a little fun in healthcare. It's not about providing services to clients or marketing products to paying customers. Organizing is about enabling communities of people to become what we call constituencies. And it comes from Latin, with, and stare is stand. So the people who stand together, constare is constituency, to stand together. And it's about not just living in community, but standing together. How we learn to stand together, to work together, to win together, to achieve a purpose, to achieve a change. And that's not about service or product, but about voice.
And this is really interesting, Pedro, and I'm glad you reminded us of that meeting that we held so many years ago. If you could see my desk, I've got a document here, which is the organizing playbook for taking on big challenges, to remind me of the steps, because we are in the midst right now of taking on one of the most difficult challenges that we have here, confronting a set of patients that we take care of that's truly an awesome challenge with a lot of knowns on how it's resolved, but needing to gather together diverse people across all the parts of our enterprise to put it together. And it's around the patient with heart failure. We have an enormous number of patients that we serve in our footprint, growing every day. I think it's one of the fastest growing communities of 65-year-old and older patients in the country right now. 1 in 8 have this very difficult illness, congestive heart failure. And it's an illness that has many preventable and actionable ways to remediate it or prevent it. But yet we find an enormous number of our patients who are in the vicious cycle of revolving door of harm and poor quality of life. And it's $1 in $3 that the Medicare program spends in our zip codes right now, almost $400 million a year and growing. And so we looked at that and said, like, what do we do? And how do we do it? And we came back to the realization that we had to put a stake in the ground as an organization that we knew we couldn't get to this year, but it was a place that we wanted to be, which is no later than 5 years from now. We wanted the quality of life and the survivability for that population of patients to be better, no less than the expected outcome compared to our peers. Certainly not to have worse outcomes than our peers. And if at all possible, to get into the top decile for that population in the country. And it was staking that ground as here's why we're organizing and why we're calling you together, hear ye, and making that case and telling that story in terms of what that life is like for a patient or patients with this illness. And that's not a fast process. We spent the better part of 4, 5, 6 months organizing around that call to action in gathering the assets that we need. And so that playbook is sitting here in the corner of my desk being applied to that challenge. And in my experiences now as a healthcare provider and as a healthcare leader and now as continued student of improvement, and I really am. So Kate has been a great teacher because I am the student, but it is a playbook that is effective and helps build that configuration of people to pull it off. And of course, staking the ground of saying, when isn't forever, here's the date.
I just want to pop in and connect the dots between what Mike's describing and types of movements. So, a movement, first of all, is an action at a large scale to affect some type of positive change in response to a systemic problem. And ideally, it is relying heavily on the intrinsic motivation of those constituents, the people standing together. And that will overcome any resistance or inertia with regard to the status quo, the way we're already doing things. And Mike, you're describing in this example what I would call a putting right from within movement in healthcare. So what do I mean by that? We are often using this approach to getting people within our healthcare systems to work together to achieve some kind of specific goal or focus by using the assets or the people of that system and potentially some of the system partners. So the surgical safety checklist is another example of that. Your work on congestive heart failure is a great example of that. And that can happen across, for example, a health system. And there are other types of movements within healthcare that we frequently see. Others could be something like mobilizing for influence. So this is the type of approach when we're trying to mobilize healthcare leaders to collaborate with others not necessarily within the healthcare system, to have some kind of influence on policy or practice that will create improvement for wider society. So examples of this could be organizations like Vote ER or Right to Health or This Is Our Lane, or I think in the UK you have Medical Justice, right? So these are people inside the formal system working to mobilize change in wider society. And a third type, and there's more than 3, but I think I'll just stop with 3, is that you can organize for large-scale change capability. So this is the kind of social movement we use when we're trying to choose priorities that are fit for a local context, but build sustainable leadership infrastructure for ongoing improvement and large-scale change. So this is, for example, Jönköping in Sweden, or Nuka in Alaska, or Rush University and the West Side United work in Chicago, or some of the work of integrated care systems in the UK. So there's a lot of ways to approach a social movement, getting so many people, again, to try to affect positive change in response to a systemic problem, ideally relying on intrinsic motivation to overcome resistance.
Today's a big day for many people here in the UK, Kate and Mike, who have been using a blend of what you just described, Kate, actually, particularly the last 2 approaches, to get a drug approved, Dexacel, for sickle cell. And it's taken at least 2 years, the group, the likes of Bola Owolabi at the National Healthcare Inequalities Directorate and the people from the Race and Health Observatory and many, many others have been working together to, of course, founded upon strong evidence, get a drug approved that's really going to help people with sickle cell. So it's a victory, and I think many of the components that you mentioned are there. Kate, strategizing or strategy. Tell us just very briefly, because in healthcare we see a strategy as a cyclical process of coming together and figuring out roughly what people need and then putting it in alignment with what the kind of authorities are asking us for, and then kind of getting it into a few pages, and that's our strategy. But give us that kind of simple 3-phrase definition of strategy or strategizing, because it's very action oriented in the domain of community organizing.
Strategy is about, well, and you have to remember, organizing is about being extremely resourceful, right? These are frequently sort of a David and Goliath history in organizing. And so it's about people taking the assets that they have to create the power that they need to achieve the change that they want. So people taking the assets that they have, they're being really resourceful with acknowledging what they already have and how to put that together in new ways to create new power through relationship and creating community around those assets, to exercise that together collectively to achieve change.
Yeah, and I'll kind of, this is very profound, and it's important that we remember it. So how to turn what you have into what you need to get what you want. And one of the beauties of understanding the contrast in the resource allocation and distribution around the world, actually, for health and healthcare is perspective. And we often lose sight of that. We complain that we don't have enough. Well, how does that fare against 50 other countries in the world that have a quarter of what you have and are still trying? So how can we get what we want, what we have, which is plenty, into what we need in order to get what we want? And there's so much energy in health and healthcare to make a difference. Everyone who works in this field is committed to serving and to trying to make a difference. And I think these kinds of tools and this kind of framing is a really helpful way to think about the changes that people want to drive. Kate and Mike, you guys were also very close to the development of a little framework. There's so many frameworks out there, but the one on the psychology of change seems to have resonated with so many people around the world. And at the center of the 5 domains is a word, and that word is agency. So can you talk a little bit about agency, and can you share some of the importance of some of the domains of the psychology of change framework?
Agency is defined as the ability of an individual or a group to choose to act with purpose, So there's 2 key components. And actually, the first one really gets to your question also about strategy, which is power, or our ability to act with purpose. And I want to talk a little bit about power. The second piece is courage, or the emotional resources that we need to choose to act in the first place in the face of uncertainty or difficulty. So together, courage and power are drivers for activating people's agency. And the work of the psychology of change is really to create the conditions for both of those things to exist in our systems in order to move people to choose to take on improvement in the face, as Mike noted, of many different challenges, busy work, and uncertainty. But power here is the ability to achieve purpose. That's what the definition from Dr. Martin Luther King. And this is really central to the exercise of leadership. The idea is that we're challenging the status quo when we're looking at improvement or change. And that requires our learning how to compensate for things that already exist within the status quo. So we have to be resourceful, as we talked about, with what we have. And fundamental to that is understanding the interdependent or relational nature of power. So if you need what I have, and I need what you have, then together we can create more power. on behalf of what we identify together from our values as a shared interest. And we collaborate, and that's what Mike's talking about in the way in which he's thinking about putting right from within, right? That we're going to collaborate in new ways with one another within our system, across stakeholder groups, bringing what each one of us brings to solve this problem. But sometimes, and this is what I find really interesting when, especially as a organizer first being introduced to healthcare, sometimes your need for what I have is greater than my need for what you have. And there's a power disparity, right? And you often see this in hierarchy within healthcare systems, where people feel powerless in the face of those who they perceive as having more power. And that I feel that, my work is then to satisfy somebody else's interests at my expense. And I've found it fascinating because for many, many years, I've recognized that in healthcare, we're healers. We're people who care for one another. And it's very difficult, in my observation, for healers to challenge power, because they're much more comfortable working with than asserting power over those that hold it. It's like approaching it as conflict, and so it coming to the world of improvement from a lens of holding power as how strategy works versus identifying change first, coming from a lens of understanding our people and the assets they have, rather than thinking about sort of the technical measurement side, right? So these are different, but actually rather compatible approaches around change. And so the psychology of change question that you asked, where did it come from? How did we put it together? I think in part it was a recognition that so much of the Institute for Healthcare Improvement's emphasis had been on technical change. And that, as Amar noted earlier, Deming, stressed psychology in the system of profound knowledge as the way people think and feel, what motivates them, what demotivates them, problematic effects of incentives, how we behave when we encounter change, and was acknowledging in psychology that improvement occurs in human systems. So people interact with each other. And so for improvement to succeed, leaders are going to have to understand and master psychology and interpersonal relationship. And so then we started to look not only at community organizing and social movements, although that was core, but also many different change methodologies, moving to scale, thinking about a variety of different, and speaking with improvers and change leaders across the world who, including, Helen Bevan, Catherine Pereira, and others who could help us imagine how to learn from many of these different methods to integrate and do a sort of a crosswalk of hundreds of tools and frameworks of these disciplines and applied methods to look at what's the relationship to improvement science and outcomes. We then really work to be more of curators of many different applied methodologies, and that's what the framework really looks at.
And given the work of healthcare improvement is always in such a human-oriented system, isn't it? Really understanding why people behave and act the way they do is pretty intrinsic, isn't it, to having any chance of improving the system. And I guess what you're opening up our minds to is fields that many of us haven't studied. And I think one of the takeaways from this is perhaps to think about how we might each take some time to learn about fields like community organizing and social movements, given resource is not never ending, right? There are finite resource for health and care. And we have, the concept of resourcefulness in community organizing is a pretty sensible one for us all to think about. The idea of using all the assets at our disposal and thinking about assets far beyond the boundaries of health and care and closer to the people we're trying to serve, again, are really core, aren't they, to the solutions that we're likely to need to find for the really complex challenges in health and care. I guess, as this conversation has zoomed by, and as we get towards the final part now, I just wondered whether you both might help us, perhaps Mike, you could go first, help us with some practical steps that you might advise us to consider taking. If you were in a conversation over a coffee with a healthcare leader or someone working in the health and care system or an improver, Mike, what who's relatively new to this way of thinking about improvement or the world or leading change, what might you suggest?
So I think I'll use an example of some really energizing recent experiences of what happens when you pool intellect and you can manifest agency and acquire resources that you as an individual or on the team has built so far hasn't had or doesn't have. In our heart failure work, it's an incredibly effective four-drug combination for this illness that can be life-changing and life-altering, but very difficult to achieve because of affordability and access and transportation coverage, let alone the sort of technical application of the science and how much physician and provider time it takes to mix that four-drug cocktail. But in this case, one of the things that we recognized is we had to start to solve for that problem for the patients who had the gap between what we knew would work and what we knew that they could have if we could figure out how to do it. And our pharmacy leader came to us recently and said, I have this idea. We know how to get access to drugs. We know how to manage some of the donut holes in coverage. We know where to start. We think we can do it by asking our own foundation to plug some of those holes for patients while we look for ways to gather the community resources and the payer resources and the other foundation grants that may solve for that more permanently or more effectively on a bigger scale. And to me, that's an example of what it takes. That in some ways, that let's go first and let's show that how it's done and the way it needs to happen, and then set that group of people loose to acquire that resource and apply it. And we're looking forward to that, and we're cheering you on, and we can't wait until you have that in place. And it's great to have you on the team. And I'm not sure that we saw that in laying out our plans and our tactics and our strategies, but it's an example of what happens when the pool of understanding and expertise broadens, and how the creativity of those individuals within their domain can bring their ideas to the table, and how often people who have those ideas might say to themselves, "This is impossible, never pull this off. I didn't," or how it changes when they realize, oh my gosh, there's a coalition here that I could be part of, and we as the coalition can rally behind them to we're in support of that idea. Let's reach the people that we can influence who can help permission what you need. And it's a type of dynamic, live, organic approach, but to the nut of the question, I think it is not only achieving the psychological safety for people to bring their ideas into the coalition or the organizing group, but it's also finding ways to have their agency become manifest and real, and being able to show that to people over and over and over again in a credible way that makes, I think, these events become real and achieve.
Fantastic. Thanks, Mike. Kate, what practical tips and advice might you give our listeners and viewers?
Well, I think particularly in today's context, I I would encourage folks to practice association. And what do I mean by association? It comes from Alexis de Tocqueville, who was a political philosopher and came to the United States in the early 1800s to understand how does democracy work and recognize that individualism could be a real threat to the politics of common purpose. And so he argued that making democracy work requires the knowledge of how to combine. So I feel myself in days like today that there is a lot of internal sense of isolation versus solidarity, fear instead of hope, a sense of self-doubt instead of a feeling that I could make a difference, a feel of inertia instead of a hope for change, and maybe a little bit of a lack of urgency due to sort of feeling all of this despair. And in contexts like that, whether you're an improver, whether you're a nurse or a clinician, a non-clinician, whether you're a citizen, one of the greatest powers we can find to activate our agency is through our relationships. It's through one another. It's through getting together with others around our shared values with purpose and finding through our commitments to each other opportunities to act. And these can be small opportunities. They can also be really big. So I would just encourage us all to think about who am I in relationship with and who am I not that I need to reach out to and have a conversation with and explore possibilities for my healthcare system, for my patients, for my team, and certainly more broadly for society.
In the context of community organizing, storytelling is one of the kind of magic powers, and there's a triad in terms of working with people and getting to commitment that I think it's exceptionally simple to remember and exceptionally valuable. So would either of you kind of care to offer what the triad is and maybe give an example of what it sounds like, the story of self, the story of us, the story of now? Just talk a little bit about that.
Mike, do you want to go on this one with regard to your use of narrative in leading the surgical safety checklist? It was remarkable.
Yeah, I think it was and really, Kate, you're the expert, but here we had this common sense and effective way for people to collaborate for a few minutes, but to collaborate reliably for a few minutes, 3 times in every case, for every case, every day. And that the fruit from that would be less harm to patients. And here's the overwhelming evidence for why that's true. And that while we're all in service of that, there are other parts to it that have meaning. And so for me, as an anesthesiologist on that team, being able to understand beyond that what to expect from the surgeon or the challenges that they thought that they were going to confront, and my way of helping them with that challenge was something that was important to me as an anesthesiologist. And for the surgeon, it was being able to have at the ready key instruments or key technology or key people at the right moment. And then in some ways, and I'm stereotyping a bit, but in some ways for the nurse, it was how are we going to, in all of the busyness in this room, make sure we're advocating for that patient and advocating and being the voice of that patient when they're unconscious and all these things are happening. And that when I could come into the conversation with a member of the team and saying, this is why I'm participating, what's important for you to have happen, or the benefit that you want to see accrue and achieve for yourself and then on behalf of the team. It was remarkable how we could get all of those constituencies having their need and their top needs met by performing this together. And that helped us, I think, get past the well, why do I want to be part of this effort? And how's that going to help me as a surgeon? And well, and I'm starting to see how that's going to help me as a surgeon, and something that's going to help you, and then we're going to do something together. And I think just having to walk through that, but walk through it with hundreds of people over time, is what the magic of it is.
Yeah, I mean, Mike and his team beautifully asked the question of who are our people and then what matters to us, right? And they recognize narrative as a way in which to learn for all of us to access sources of value that afford us the emotional resources, or what I called the courage to act with agency, to make choices, to respond to challenges. And the use of narrative is then rooted in courage or an emotion, which is around informing us of what we value in ourselves, in others, and in the world. That's the self, us, and now. And it's through these emotions that we express values to others in a way that they experience it, or that we elicit from others. Like, we ask questions about what matters to them. So Mike and his team were speaking of values in a really real way by telling stories. And stories help us access those emotions. And it was really beautiful. I remember, I'm going to bring us all full circle to when you first chimed in, Pedro, because I met you and Mike on the same day in 2010 at that organizing workshop with Institute for Healthcare Improvement. And I remember Mike standing up and sharing a very moving story about his call to leadership in supporting colleagues to use and adopt the surgical safety checklist. And he expressed how it was based on his faith and his own experience of injustice. In fact, I remember him saying the feeling of guilt and shame that he felt, a betrayal, when a patient in the care of his hospital had a bad outcome that was entirely preventable if the surgical safety checklist had been used. And we often now describe that as moral injury. It's a term that we use to describe when healthcare workers feel they're forced to act against their moral beliefs due to system pressures. But here, it was about failing to get colleagues to adopt a new behavior rather than having enough resources to provide adequate care. And the limiting force was inertia, people's existing habits. And what Mike and his team did so beautifully is that they used community organizing practices like having an intentional relational strategy of sitting people down. He said they had hundreds of one-to-one meetings across all different types of practitioners affected by what happens in the OR. And they discussed and elicited their story of why this work mattered to them and invited others to share why it mattered to them. And they, on the basis of their values and listening to each other, formed commitments around using the checklist and inviting others to join them. And that sounds very simple, but it took a very long time.
Such a powerful story to end on. Kate, Mike, huge thanks for guiding us through this conversation, bringing your own insights and wisdom in, and your own personal stories too, for us all to learn from. Pedro, what are you going to take away from this conversation?
So many takeaways, and I'm trying to associate, to use Kate's word, the key lessons. To me, one of the things that our listeners are going to be able to grasp from this conversation is tools. Very practical, very pragmatic, and definitions that are grounded on practice and this inclination to learn by doing, which is very powerful. You know, everything that Mike and Kate have shared is grounded on acting and then adapting as you learn. And that's the spirit of improvement. This is a podcast called Conversations in Health and Care Improvement. And this has been a very pure conversation in health and care improvement that is continuously enriching kind of the community with new concepts, new ideas, and new tools. So it's been a gift from both of you to have you with us.
Fabulous. Thank you so much, Pedro. And huge thanks to you both, Mike and Kate, for joining us for this episode. Thanks very much, both of you. For all our listeners and viewers around the world, keep the conversation going, and let's stay connected and associate and make the world a better place. Thanks, everyone.